Pulmonary hypertension is categorized into 5 World Health Organization groups based on pathophysiology and clinical features. You will notice on this slide, I have pulmonary arterial hypertension in red. There is a distinction between pulmonary artery hypertension, or PAH, and pulmonary hypertension, or PH. PH is an umbrella term encompassing multiple clinical conditions. PAH is classified as WHO Group 1. It is precapillary and associated with the proliferative vasculopathy pictured on the upcoming slides. PAH will be the focus of our discussion today. PAH is a progressive disease affecting the arteries of the lungs. The pulmonary arteries are the vessels that carry deoxygenated blood from the right side of the heart to the lungs. In pulmonary arterial hypertension, the right side of the heart has to work harder and harder to pump against the increased pressure in the pulmonary arteries. Just like any muscle that is constantly worked, it grows bigger. Unfortunately, when the right heart becomes bigger, it starts to take over space the left heart needs to effectively pump. As the size of the right atrium and ventricle increases, the ability for the chambers to efficiently pump blood diminishes, eventually leading to right heart failure. On the slide, the bottom circle depicts the narrowed artery, which causes a backup of pressure, eventually leading to enlargement of the right ventricle, pictured in the center of the slide. Note that the right ventricle size is larger than the left ventricle, which is not normal anatomy. The incidence and prevalence of PAH in the United States or North America is unknown. It tends to occur more often in women and is commonly diagnosed in the 4th and 5th decades of life. However, there is an increasing prevalence in the older adult population. PAH is a serious, complex, and progressive illness characterized by the remodeling of the small pulmonary vessels. Healthy vessels start out like open pipes that the blood can easily travel through, as pictured in the top of the diagram. As the disease progresses, the pipes become more obstructed. The pulmonary arteries in PAH patients are being assaulted by 3 main problems. Illustration A depicts vasoconstriction, meaning the vessels are tightening. Illustration B, cell proliferation, meaning the cells on the inside of the blood vessels are multiplying. And C, the formation of plexiform lesions. These cause the vessels to become thicker and stiffer. Lastly, blood clots may form inside the blood vessels of the lungs, depicted in drawing D. This further obstructs blood flow. As the vessels become narrower, the pressure inside the vessels becomes higher, much like when you block the end of a garden hose with your thumb and water squirts out at a higher pressure. The increased pressure of the blood flow does additional damage to the diseased arteries. One of the most important distinctions to make is whether a patient's pulmonary hypertension is precapillary or postcapillary. True PAH results from vasoconstriction and remodeling of the pulmonary arterial vasculature. It is a disease of the vessels. Damage is being done to the arteries and arterioles that are transporting blood to the lungs. This is a precapillary process. The origin of the problem precedes the capillary bed. This is in opposition to pulmonary hypertension that is a result of increased pressure on the left side of the heart. Left heart disease causes pulmonary venous congestion and increased pressure within the capillaries. Ultimately, it reflects as increased pressure in the pulmonary arteries. However, the origin of the problem is post-capillary. The hemodynamic definition of precapillary pulmonary hypertension is a mean pulmonary artery pressure at rest greater than or equal to 20 millimeters of mercury in the presence of a pulmonary artery wedge pressure less than or equal to 15 millimeters of mercury. These measurements can only be taken accurately during a right heart catheterization. Other measurements, such as the right atrial pressure, pulmonary vascular resistance, or PVR, which is the resistance the right ventricle must overcome to pump blood into the pulmonary arteries, and cardiac output, the amount of blood your heart pumps, are also very useful to determine how severe the pulmonary hypertension is. The mean PAP cutoff to define pulmonary hypertension has been changed recently. The prior limit for abnormal was a mean PAP of 25. This was a conservative cutoff value. At the 2019 World Symposium, the new definition was established using a more scientific approach. It is important to note that an elevated mean PAP in isolation does not define PAH. There are three categories of pulmonary hypertension: pre-capillary, post-capillary, and combined pre- and post-capillary. Our focus, pre-capillary pulmonary hypertension, requires that the wedge pressure, which is a surrogate for left atrial pressure, be less than or equal to 15 and the PVR greater than 3 Woods units. This slide shows the 5 World Health Organization groups of pulmonary hypertension and their associated conditions. Group 1 PAH is classified as idiopathic only once all other causes have been excluded. Amphetamines and certain chemotherapy drugs can cause PAH. Connective tissue disease, especially scleroderma, can lead to PAH. Persons with HIV, liver disease, or congenital heart disease are at risk for developing PAH. Schistosomiasis is a common cause of PAH outside of the United States and Europe. A subclass of Group 1 is pulmonary veno-occlusive disease and pulmonary capillary hemangiomatosis, which are rare conditions outside of the scope of today's lecture. Group 2 is post-capillary. This is elevated pulmonary artery pressure related to left heart disease. These are the patients with left heart failure or valvular disease. This population does not respond well to our vasodilator therapy because the left side of the heart cannot handle the increased blood return. Group 3 pulmonary hypertension is due to lung disease and/or hypoxia. These are our patients with severe emphysema or interstitial lung disease, or people with untreated severe sleep apnea. Group 3 patients may have precapillary hemodynamics, but the pathology is not a primary vasculopathy. Rather, damage to the lung tissue causes damage to the pulmonary vasculature, or hypoxia causes vasoconstriction of the pulmonary vasculature. Group 4 relates to pulmonary artery obstructions. This is also a precapillary process. It is most associated with chronic thromboembolic pulmonary hypertension, or CTEPH. This is when pulmonary emboli occlude either the small or large arteries of the pulmonary system. This is the only potentially curable form of pulmonary hypertension. Group 5 encompasses PH due to unclear or multifactorial mechanisms. Patients with sarcoidosis, thyroid disorder, myeloproliferative disorder, and other cancers would fall into this category. If any of these processes cause increased pressure in the pulmonary vasculature, you may see precapillary hemodynamics. This is not to say that some patients may fall into more than one of these categories, especially as patients grow older. This is not easy or obvious, which is why referral to an expert center is so important. Our challenge is to determine which group is the main contributor to the problem and to treat accordingly. Symptoms of PAH are nonspecific, which can lead to delayed evaluation and diagnosis. the effect of elevated pulmonary artery pressures on the right ventricle is the critical determinant of morbidity and increased mortality.